The next, last but not the least, our next speaker is Dr. Prakash, who needs no introduction. He is one of the leading retina surgeons and administrative of Contrast Eye Hospital, Calicut. So we'll be presenting Look Out for the Hidden Surprises, that is, the management of intraocular foreign bodies.
Thank you, Dr. Shamshir, and good evening to all. So, intraocular foreign bodies constitute 40% of open globe injuries, and majority happens at workplace. In our hospital, we see mostly from the most common cause is grinding. Tiles grinding is the most common. Next is grass cutting, followed by the classical chisel and hammer. And we have something very special to our area. What you see in the basket, these are not coconuts. These are our Nadan bombs, which are we are very much expert in making, and this also cause all kind of foreign bodies, and usually seen in young males. And the outcome depends on the size of the foreign body, the zone of injury, as well as the complications associated with it. So consequences of IOFB can be immediate consequences, which again can be mechanical, chemical. Mechanical injuries can be the wound, bleeding from that, iris damage, cataract, retinal breaks, retinal detachment, whereas immediate chemical injury can be chalcosis, which is seen with pure copper. Endophthalmitis and inflammation can happen. Secondary complications include mechanical, again, glaucoma, PVD, retinal breaks, retinal detachment, PVR. Chemical includes siderosis caused by the iron, chalcosis, again, metallosis, and chronic hypertony can happen. So whenever you are faced with a foreign body, always take a careful history. What was the activity? How did it happen? And type and mechanism of injury. So in a rural setting, organic foreign bodies can be seen more common. They result in fungal infections. And time since injury is again very important. And always look for corneal haze, vitritis, etc., which are signs of infection. And if it gets prolonged, there is a higher risk of capsule formation and the foreign body getting hidden. So the examination starts with a careful slit lamp examination. Look for the corneal entry wound. The size of the entry wound will give you an idea what is the size of foreign body that is going to be inside. And always beware of hole side, whether it is in a hole in the iris or even a hole in the lid. There was a case where there was a small lid hole and patient had 6/6 vision. So it was not bothered to check the fundus, and patient actually had an intraocular foreign body which had gone through the lid hole. So never even neglect a lid hole. And anterior chamber, you can have the foreign body in the angle. So do a gonioscopy, especially when you have a chronic recurrent uveitis in a patient with a corneal scar. And fundus examination, nothing beats indirect ophthalmoscopy. Do it as early as possible. Get a dilated fundus examination, because soon the cataract will develop. You won't be able to see the foreign body. So nothing like seeing it directly with your eye. But if many cases it is not possible, so B-scan is the most important tool which is needed for localizing a foreign body as well as diagnosing a foreign body. Again, the sensitivity of B-scan is much higher than that of CT scan. Even you can pick up small foreign bodies which may be missed even on a CT scan. So it's important the technique. Once you have a suspicion of foreign body, you have to do a careful B-scan. Bring the area of attention to the center, so that if it is in the periphery, you might miss a high reflectile particle. Reduce the gain always. So whenever you have a foreign body, it will cause a spike which is more than the scleral spike. So reduce the gain and see whether it is still higher than the scleral spike. Then it will always cast, most of the metallic foreign bodies will cast a shadow. So this has to be done. Even this case, the first in the picture here, on an apparent B scan, you might have missed a foreign body. Once you reduce the scan, you see that there is a foreign body in the sclera. The double optic nerve sign will give you with the tell away sign here. So you can see that foreign body after reducing the gain. And again, CT scan is very important. Even if I pick up a B scan foreign body, usually do a CT scan, because that's the best form of documenting a foreign body. The next, once you have diagnosed and localized a foreign body, the next part is to plan and timing of surgery. Timing of surgery, it's a little controversial because many people recommend immediate surgery. Both has its own advantages as well as disadvantages. Immediate means you are reducing the risk of endophthalmitis. You are also reducing the risk of PVR. Also, the PVR foreign body does not get encapsulated, and it means a single procedure for the patient. That's along with the primary repair. Whereas planned means you do a primary repair first, then you do a intraocular foreign body removal removal in a second sitting. So here you have an improved control of inflammation. There is a spontaneous development of PVD, making the VR surgery easier. There is reduced risk of bleeding because inflammation has come down. The corneal edema is less and view of the fundus is better, and you can plan your surgery. So in an emergency surgery, you may not get the instrument that you wanted. So that is very important. And immediate intervention is advised in certain scenarios where you have already a retinal detachment, or if there is an endophthalmitis, you may have to go in early. So the route of removal depends on two things: what is the status of the lens, whether the lens is already damaged or not, and what is the size of the foreign body. If the lens is clear, then you look at the size of the foreign body. Whether it is less than 6 millimeter, then you can remove it still through the pars plana without causing much damage. If it is more than 6 millimeter, even if the lens is clear, it is better to do a lensectomy and remove it through the limbal route. And lens is damaged, then there is no issue. We go ahead with doing through the limbal route. So I'll go through few examples of different types of foreign bodies. Here you have a small foreign body. The lens is injured. The B scan shows the foreign body lying in the vitreous. It's not, so that means it's a very small foreign body. It's a light foreign body. It's not very heavy. So here you have a corneal tear, as well as you have lens injury. So the lens is removed. You can see the PC rent there through which the foreign body has gone inside. So all the cortical matter, everything is cleared very well. First you need a good view of the fundus. So everything has to be cleared first. Then a 25 gauge pars plana approach is done, and vitrectomy is done, and you have to induce a PVD. Many of these cases PVD may not be there. So you can see in the periphery the assistant is depressing, and the foreign body, you, as soon as it is seen, you don't grab it with your forceps, because you will pull all the vitreous along with it and cause a retinal dialysis. So the foreign body has to be cleared of all the vitreous, and for these small foreign bodies, when they fall back onto retina, usually does not cause any damage. But this is not the case with heavier foreign bodies. They cannot be let to fall to the retina. So here most of the time I take with a forceps so that there is no slippage. This helps you to, here the foreign body is picked up with a 25 gauge magnet. Then it is brought through the same PC rent through which it has gone inside. It is brought into the AC. And then this is iris claw holding forceps. This is very useful. Other than using a McPherson, you can, this gives a very stable grip of the foreign body. The foreign body is removed without slipping back into the retina. Then the surgery does not end there. You have to clear the vitreous peripheral base, because there is going to be a PVR later, and the endolaser is done to the site of impact, and then a 3-piece IOL is placed. This is another case where you have again a small foreign body with the lens is clear. The earlier case we had the lens was damaged, so this is a small foreign body, so we'll remove it through the pars plana only. We won't disturb the lens. So again a vitrectomy is performed. This is also more or less similar foreign body which is hanging in the vitreous. It is let to fall after vitreous is cleared around it. Then the vitrectomy is completed. Here an additional fourth port is placed, and the other one port is enlarged to introduce the forceps. Through the fourth port, a chandelier illumination is placed so that you can bimanually remove the foreign body. Magnet is introduced. The advantage of magnet is that it gives you you can manipulate the foreign body without letting it fall back. So here it is picked up with the forceps, then it is aligned to the long axis of that forceps. Because when you directly pick it with the forceps, you have to pick it up on whatever position you get it. You don't have a chance to align it. So when you have a magnet, you align it properly so that it comes out through you want the smallest diameter to come through the sclerotomy. Then the sclerotomies are closed. Again, vitrectomy is completed. Fluid air exchange is done. Endolaser is done to the impact site, and tamponading agent is placed. So here you have a large intraocular foreign body, and the lens is already damaged. So the corneal, you can see the corneal tear which has been primarily repaired. There is a large iris injury here. Iris is traumatized badly. So this corneal tear tells you that this foreign body is going to be large, and all the residual cortex or nucleus, everything is removed. Then the vitrectomy is done. There is as expected, there is a large amount of vitreous hemorrhage. There is some amount of subretinal hemorrhage also at the impact site. Everything is cleared, and the foreign body is PVD is induced. Everything is cleared. And here the foreign body is actually encapsulated. It is inside a capsule, and it's in under below the plane of retina. There's a retinal tear, and it's impacted in the choroid. From there, it is slightly lifted. The capsule is removed. And again, these are foreign bodies which you should remove always through the limbal route, whether lens is there or not. So here again it is brought back, and here I'm using the McPherson, but the iris claw lens forceps would have been ideal, because there is always a risk of corneal damage when you are using McPherson. Whereas iris claw gives a protection against the corneal endothelium for the foreign body. This was a little older video. Nowadays I use only iris claw holding forceps for removing it through the anterior chamber. So it is carefully brought out from the anterior chamber. So that is a foreign body matching the size of exactly the size of the corneal tear. But here in this case, there is a lot of retinal damage that has happened. Sorry. So you have to do clear all those multiple retinal tears are there, which has to be tackled. And most of these cases, it is better to put silicone oil, because otherwise severe PVR develop, and detachment can happen of retina. So this is a large IOFB. Here the lens is clear, but the IOFB is large. So as I told earlier, we will have to sacrifice the lens. So initially vitrectomy is done, so that before you have to identify the foreign body. So it is embedded in the inferior retina. It is it is encapsulated. PFCL is placed at the macula, and the lens. Sorry. Sorry about that. So it's in the peripheral vitreous. So it has to be removed after clearing all the peripheral vitreous. Here the assistant has to depress very well. You have to clear everything. It is encapsulated. It is actually incarcerated in the choroid as well as pars plana, part of the ciliary body. So the assistant is depressing. That's a depression. That's amount that you are seeing is a depression by the assistant. Then it is slowly cut into that area. So that's a foreign body. That's again taken with a magnet. From once it is cleared, it is it should not be let to fall back onto the retina. So it is held firmly with a magnet, then brought to the anterior chamber. The lensectomy has already been done. So it is brought through the limbal route. Here a large limbal incision is made, and the iris claw holding forceps is placed. And gently from the magnet it is transferred to the. So here the advantage of the magnet is, even if you slip, it won't fall back. It will be again caught on the magnet. So that makes it very safe. So again, you have to tackle all the posterior segment problems. There is a multiple retinal tears which has to be lasered, and a tamponading agent has to be placed. So this is all in the syllabus. Then something happens where you see that, if you go back here, you can see that on the CT scan, you see a foreign body which is coiled inside the eye. This was actually after a blast injury. The Nadan bomb which I was showing, that was injury after that. And you can see a foreign body which is almost extending the entire length of eyeball from the anterior portion to till the posterior, almost till the optic nerve. Sorry. So it was a long foreign body, probably a wire foreign body. There was traumatic cataract which was removed. Vitrectomy was done. There was vitreous hemorrhage. We thought that some portion of the foreign body may be seen inside, or the entire foreign body may be inside. But after vitrectomy, it was surprising to see that there was no internal foreign body. It was a clear retina. So we went back to the scleral tear which was repaired, and started inspecting the scleral tear area. Can we get any hint of foreign body in that area? In spite of being such a long foreign body, we were not able to find out. Next, and we actually even hooked the muscle and explored the sclera completely, but couldn't find the foreign body. Now, as I was depressing that area under the ciliary body epithelium, I could see some metallic shine. I thought probably there is a foreign body there. So it was nudged from depressing from the other side, and it was caught with the forceps, and it was pulled out. To our surprise, it was a very, very long foreign body, and it was entirely in the suprachoroidal space with no portion of the foreign body either on the sclera or inside the eye. So you can see it coming out. There is no end to it. It is still coming. I don't know how these foreign bodies go and lodge themselves in the suprachoroidal space without causing damage. So this also can happen, and as I told earlier, it is very important to avoid falling back of the large intraocular foreign bodies. Go bimanual, use magnet as much as possible, and always have the right instrument. And don't think PFCL is a solution when foreign body falls back. Studies have shown that the velocity inside PFCL as well as saline is the same. So if you have a very large foreign body, the best option is to use silicone oil inside. Do a fluid air exchange, put silicone oil and remove it under silicone oil, because inside silicone oil the velocity is very less, it does not cause damage. So to conclude, foreign bodies are very dicey situations. You have to always suspect them from careful history and look for these small signs which will tell you there is a hidden foreign body inside. Localize them properly using all your modalities of imaging, B scan, CT scan, and have planned the surgery thoroughly, have the proper instrument, correct technique. That will avoid you many medical legal cases and also save the patient some vision. Thank you.
Thank you, sir, for this wonderful and well explained